and we'll get started right now. So, hello everyone. My name is Hwang, and I will be moderating today's event. I'm on the board currently for Net Impact Chicago, and just wanted to give you a little bit of information around who we are. We are a nonprofit focused on bringing together a professional network community of people where we can discuss, talk, and network with other like-minded individuals around topics that are impacting both the planet and people. And we'll also look at providing a safe area for people to talk about these pressing issues. In 2020, we've had a lot of virtual events this year, given the current circumstance, highlighting racial issues, coming up with the right go-to-back-to-work strategy with having the employee and human-centric mindset to it. And also, we've had a really cool webinar around the future of water. We typically do have things like happy hours and networking events, but given our current situation, we will resume that when it is deemed safe to do so. So as we talk about today's topic, we really wanted to talk to everyone about the state of racial disparities and the inequities that exist in healthcare. I think with the 2020 election, it highlighted two of the most pressing concerns facing the United States today, which include racial discrimination and the ongoing coronavirus pandemic. These issues have accelerated the importance of the two, with the pandemic taking a disproportionate health and economic toll on people of color. While we were preparing for this event, we did some research, and according to the Kaiser Family Foundation, nearly 6 out of 10 Black adults and 4 out of 10 Hispanic adults report experiencing race-based discrimination in the past year. I mean, despite being long documented, despite all the studies and research out there, racial and ethnic disparities in healthcare have persisted and in some cases widened over time. I think the pandemic has definitely highlighted that. These disparities are just symptoms of a broader social and economic inequities that are rooted in structural and systematic barriers across sectors, which include racism and discrimination. So today, we do have a few experts here with us today to talk about these issues and what specific initiatives like the All of Us research program today are doing to combat these issues. So I'll quickly introduce our speakers before we get into it. Shannon Russell. I personally know Shannon. We've worked together at Slalom, one of my dearest friends. She has deep knowledge of the healthcare industry, which includes both policy and health delivery. She has her master's degrees in health administration and bachelor's of science in health information management from St. Louis University. She's going to be talking to us today about a lot of these issues. So please welcome Shannon here. Monica Rodriguez. She has been leading the recruitment initiatives for the All of Us research program since 2018 as her role of the Director of Communications and Engagement. She's been in a lot of roles. She's been part of the Illinois Precision Medicine Consortium, and she serves on various national Institutes of Health committees, and really has a drive and mission to really build sustainable partnerships within around healthcare. And then lastly, Jenna. She is part of also the All of Us research program and has been in that role since 2018. Right now, she is a research study coordinator senior for various levels of staff and projects within the All of Us research program. And prior to relocating to Chicago, Illinois, she was in Alaska and supported health and wellness nonprofit organizations focused on serving underprivileged individuals of ages, primarily in rural areas. So we do have a stacked speaker lineup here. What we will do towards the end is we will set aside some time on the call for Q&A. If you see in the Zoom chat, if you have any questions, please feel free to throw those in, and we'll address those at the end of the call. But just given the short amount of time that we have, I will hand it over to Shannon and then have her walk us through her section, and then we'll end with some information around the All of Us program.
Great, thank you, Ben, and welcome everyone tonight. Thanks for coming and listening. To start today's conversation, we're going to define a few key terms that you may hear throughout our talk tonight, but you may also see related to the topics of racism in healthcare. The first term is health equity, which is any one person having an equal and just opportunity to live their healthiest life. This is really the goal of what we're working towards in our society and in our health system, an experience where human health is equal across all groups of people. On the right, we see a few things that we want to eliminate in our current health system. The first is racism. Racism is the belief, whether it's conscious or unconscious, that a person or group of people can be superior or inferior based on their race. And discrimination is when that belief gets put into action and results in a prejudiced treatment. In today's conversation, we're talking about discrimination specifically about race and about racism, but a person can experience discrimination of other forms as well. Racial essentialism is the idea that a certain biological trait is shared by all members of a racial group. This idea has been discredited for some time now, but there's still some lingering effects. One example of this is the belief that people who are Black have a higher pain tolerance than non-Black people. And this belief was used to justify the use of violence in the times of slavery. And in a less radical way, this idea persists in today's healthcare environment by Black patients being less likely to receive pain medication. And our last term is health disparities, which are plausibly avoidable differences in health status. So when we look at a health indicator, such as life expectancy, the prevalence of a specific illness, the survival rate for that illness, et cetera, and there are differences of those indicators across different groups of people, that's a health disparity. Health disparities usually arise as the downstream effect of racism, discrimination, and racial essentialism. So when we address all of these things and we take action to close those gaps of health disparities, that's when we achieve health equity. Next slide, please. Great, thank you. Another note about racism, recently, about 3 weeks ago, the American Medical Association declared racism a threat to public health. The American Medical Association, for those who may not be aware, is a professional organization supporting doctors and medical students, but they also have a lot of lobbying power to improve patient care and public health. Their resolution included 3 key declarations. The first, it declared racism a public health threat and acknowledged that historic and current practices of discrimination based on race have caused health disparities and exacerbated existing ones. Second, they established a distinction between race and scientific terms such as biology, genetics, and ancestry. So race should be used as a social term. It's a social construct and not a proxy for any of these scientific terms like biology or genetics. So when physicians are looking at a patient and considering their risk factors, the AMA is urging them to not consider race a risk factor and instead to focus on that patient's ancestry, that patient's genetic code, their experience of racism, and the social determinants of health that they may have. And lastly, they call for the elimination of the term racial essentialism. Following the declaration, the AMA is doing a few things to follow up on this and take more action. The first is compiling a list of best practices for their stakeholder physician groups and medical schools so that they can better care for their non-white patients and support their non-white members, such as providers at that hospital or physician group. Also partnering with medical schools and continuing education programs to review and improve their existing curricula, as well as create new curricula that explain systems of racism and practical ways to address the health effects of racism. And lastly, they're writing recommendations on how to rewrite clinical algorithms that can be used in diagnosis or treatment, such as medicine dosing. Some of these algorithms currently include race as a factor, and so they're writing recommendations on how to eliminate that factor in those algorithms. So though the AMA is making this distinction that race is not a proxy for biology or genetics, it's also not technically considered a social determinant of health. So we're going to talk about that on our next slide here. Social determinants of health are lifestyle or environmental factors that contribute to a person's health status. And in more recent years, these things are seen to be more influential in impacting a person's health than their genetic code. So there are several different types of social determinants of health, and you see several of them listed out here. There can be factors related to your economic stability, such as whether you have employment or a source of income, what your current debts and expenses look like, and whether you have some sort of financial support system, such as a relationship with a bank. Next are factors related to your physical environment, such as, do you have a place to live? And is it safe and structurally sound? Does it have clean air and water? Are there parks nearby? Are you able to walk around your neighborhood? All of these things play a factor. Education. Do you have access to a school, one that uses your language? What level of education do you have? And do you understand conversations about your health? Food. Do you have access to a grocery store? And does it have affordable options and healthy options? What is your social life like? Do you have a support system or a sense of community? Do you endure chronic stress and have ways to cope with it? Do you witness violence or have you been a victim of violence? And lastly, factors related to our healthcare system, such as, do you have health insurance? Is it affordable? Do you have providers nearby, ones who speak your language or understand your culture? And do those providers know how to do the treatments and services that you require for your health needs? All of these social determinants of health can impact any person's health or community's health. And some of the ways that we can measure that some of the ways that we can measure health status and health outcomes and the impacts of all these determinants combined with our biology and our genetics are the health outcomes you see along the bottom. So things like mortality, morbidity, life expectancy, et cetera. So though racism isn't a social determinant of health, it's a through line that can impact any of these different systems. Great, thank you. Tonight, we're going to look at life expectancy in particular as one particular health outcome in our city of Chicago and look at the disparities that exist with life expectancy. So on the left, you see a map of Chicago broken into our 77 different community areas, and the shades of blue indicate the life expectancy. The darker the blue, the longer the life expectancy. Based on this color scale, there's about a 20-year difference in the highest and the lowest communities. And you can't quite see this on this particular map, but I can share a statistic that related to this. In 2015, Streeterville had a life expectancy of 90 years old. Streeterville is predominantly white, predominantly affluent, and just 10 miles south of that in predominantly Black neighborhood of Englewood, the life expectancy was 60 years old. So that's a 30-year age difference with only 10 miles in between them. And then looking at the right side of this slide, we see life expectancy by race. So this could be across any neighborhood in Chicago, not broken down by community, just looking at race across Chicago. The highest group is the Hispanic population with a life expectancy of 84.7. Next is non-Hispanic white with 79.2. And at the bottom is non-Hispanic Black with 72.4. So about 12 years difference between our highest and lowest groups. So this is a racial health disparity that Chicago is addressing in order to achieve health equity. But you may remember that race is not a determinant of health, but our community areas are, and a really big one. They determine how close you are to schools, employment, grocery stores, health providers. So when we look at this blue map of Chicago, let's try layering in race and see how that plays out. So next slide, please. So here is our first view. This is our group with our highest life expectancy, the Hispanic population, the life expectancy of 84.7. So we have our same map on the left here, this life expectancy broken by community area. On the right, we see that same map, those same 77 community areas, showing the percent of population related to that particular race group. So this one is showing the Hispanic population with the darkest color of purple, meaning that that community area's population is 70% or higher of Hispanic population. So you can see that the community areas that are predominantly Hispanic are in this like southwest corridor region, the far northwest side, and then the areas adjacent to the state of Indiana. And then when you look across the way at the blue map, you see that these areas have that bright blue or darker blue shading, so matching up with that citywide life expectancy of 84.7. So let's take a look at the next group, which is our non-Hispanic white group with a life expectancy of 79.2. The communities with the predominantly white populations are along the north side of the city and then expanding into the far northwest. And then you see a couple of pockets around the perimeters. And again, the blue chart on the left is still showing that bright blue, that dark blue shading. And then here's our last group. So this is the non-Hispanic Black. That purple map completely changes. Completely different community areas are highlighted. And this is our group with the lowest life expectancy of 72.4. These predominantly Black neighborhoods, it's almost like a direct inverse from what we were just seeing. So we see that the communities are in the south side as well as the west side here. And when you look at the blue, it's almost that same inverse of the purple, where these are the community areas that are lacking or scant in the dark blue shading, and that instead we're seeing these lighter blues, these medium hued blues. So all this to say is Chicago is a very diverse city, especially for a large city, but it's one of the most segregated. So though race isn't a social determinant of health, our physical environment is, and we see a really strong correlation between these things in our city. So we tend to see a really strong correlation in our health disparities by area that match our health disparities by race. And your neighborhood plays such a strong role in your life. It determines where you shop, where you eat, where you live, where you work, that all of these things are having this impact. These disparities in life expectancy, as well as other health disparities that exist, have prompted Chicago to prioritize 5 key areas for improved health and health equity as being the ultimate goal: promoting behavioral health, strengthening child and adolescent health, preventing and controlling chronic diseases. So this could include things like asthma, diabetes, and cancer. Preventing infectious diseases, which predominantly focus on sexually transmitted infections. And lastly, reducing violence. Each of these buckets has several of their own objectives, plans, indicators, KPIs, but I highlighted a few of them here. Anything that's shaded blue has a specific goal that's tied to an outcome with a particular part of the city that's identified. So this is more of a location-based goal. And anything shaded in the purple text is tied to a specific race group, or where there's an objective related to a disparity based on race. So I'm not going to go through all of these things, but they're all available on the Chicago public health department's website, but I will call out a couple just to give you an idea of what we're working towards here. There's one goal related to preventing and controlling chronic diseases, that's improving chronic disease management. And within that, there's one particular indicator that is focused on the prevalence of asthma among Black youth and the associated number of visits to the emergency department. So a Black child in Chicago is twice as likely to go to the emergency room with asthma than a white child. So the city has plans to take action to address this, including implementing asthma awareness and intervention programs where children live, work, or not work, learn, live, learn, and play. Also implementing home-based environmental interventions and promoting self-management programs. And then another goal that I'll highlight here is related to reducing violence. And it's that first bullet point there, decreasing the incidence of victimization and exposure to violence and strengthening community protective factors. One of the indicators included with this goal is reducing the rate of gun-related homicides among Black men. In Chicago, Black men are victims of gun-related homicide at 18 times the national rate. Some of the actions put in place behind this goal are working with individuals and families on prevention, early intervention, and response strategies, and more expedient post-action response briefing and implementing post-action analysis, and providing stronger and more deliberate support for survivors. But beyond Chicago, there's things that we can be doing to achieve health equity, and that's what we're going to talk about on our next slide here. So these are some things that we can do both within the healthcare system and beyond it. Within healthcare, we can do things like expand access to health insurance and expand our coverage. We can improve our representation in the provider workforce, implement cultural sensitivity training, and then create safe ways to escalate issues when needed. And then beyond healthcare, we can work to improve food security, access to affordable housing, improve the economic vitality of our communities, and ensure that transportation and parks are available in all neighborhoods. So I also wanted to bring attention to one group that's doing a lot of this work here in Chicago as a good example of ways that we look at health equity as the effect of addressing racism and other forms of inequity across all systems. And that group is called Westside United. It's a collective group of healthcare institutions, local businesses, the school system, nonprofits, faith institutions, and even just residents of the community who want to help out and be participants. All of these folks located in the west side of Chicago, together coming up with plans and investing in their community with the goal of an overall healthier community on the west side of Chicago, which will in turn mean greater health equity across the entire city. So I wanted to call them out as a good example of doing some of this work. And another way we can work towards health equity is through representation in our research, which I believe is what we're going to hear about next. Thank you for listening.
Thank you, Shannon. I will hand it over to Monica and Jenna.
Thank you. As Ben had already stated, my name is Monica Rodriguez, and I direct the communications and the engagement for the All of Us research program at Northwestern University. And on behalf of the Illinois Precision Medical Consortium, I also am the liaison to the National Institutes of Health for our consortium and All of Us related aspects. Next slide. So really to give you a brief overview and summary, the All of Us research program is trying to recruit 1 million or more people to share their health data or their health story, you could say, with the research program with the aim of being able to accelerate medical research breakthroughs and outcomes. And next slide. What we are really trying to do is an initiative called Precision Medicine. For those of you who are not familiar with precision medicine, it's the idea that we are looking at a variety of data points to inform how we get individualized care. So traditionally, the way that we've mostly experienced medical care since about the 1980s has been a very one-size-fits-all approach. It has been primarily that someone has a sickness or a disease and they get treatment based on what the expectation of what you should do for that disease is. What precision medicine is saying and what we're trying to move our whole healthcare system towards is the idea that we want to look at how lifestyle, biology, and environment all contribute to an individual's care. And Shannon touched on several of these when it comes to the social determinants of health. And really we see a huge impact. Now, what that means for our, and we're going to dive into it a little bit more when it comes to what we consider underrepresented in biomedical research communities, but is the idea that right now, most of the clinical trials that have taken place, because they've taken place with not including most racial and ethnic minority groups, the impact that has had is that we don't have enough data for researchers to make informed decisions to support treatment plans that are tailored to the individual differences that we each have. And so what we have is a very Caucasian-based solution for what is an incredibly diverse healthcare problem in the United States. So next slide. A couple of things that are innovative about this research program. One, so this research program is funded through the 21st Century Cures Act. It actually first was initiated when Obama was in office. And we're looking again at that scale of 1 million or more people, so quite ambitious. The next closest thing is the UK Biobank with 500,000. We are going to be mentioning a lot of the values that we have as a program, and that's really one of those values is that we see participants as partners. The idea that we're not just asking for you to give us your data, which when we're talking about underrepresented communities and specifically racial and ethnic communities that have experienced historical abuses when it comes to health research, where we have to build trust, we have to be able to have a value add or some way in which we give back to those communities, and really where we're building a partnership with individuals and where they have the autonomy to decide how much participation they want to have in the program. So that's an incredibly important piece. We're looking to see this program through for 10 or plus years. So we are in the third year, and we are, as I mentioned already, looking at a variety of data points, which we will get into more detail, but some of those being self-reported information through surveys, the electronic health record, which as a member of a clinic or an HPO, healthcare provider organization such as Northwestern, that's how we will kind of pull that data. Now, everything that we do with the research program is de-identified, so for pure privacy and security purposes. Next slide. I want to give you a snapshot of what it looks like for the Illinois Precision Medical Consortium. Now, the IPMC is made up of Northwestern as the lead site, but it also includes the University of Chicago, the University of Chicago, and North Shore and Rush. We have a lot of federally qualified health centers that participate, like Howard Brown or Erie Family. And so the network, the engagement network of how we are trying to kind of promote and educate the population across the United States really extends just much farther past than just your traditional medical healthcare organization. So we have had, since the program launched, we have over 362,000 participants who have enrolled and begun the initial steps of enrollment. And I will hand it over to Jenna here in a moment, who will explain what that actually looks like for the participant. And we have over 271,000 participants who nationwide have shared and enrolled in the program and completed the initial steps to the point where they've shared biosamples with us. So we do collect a blood and a urine sample. Next slide. When we're looking at, I mentioned before, these underrepresented in biomedical research, traditionally what we're looking at, and some might think, is just race or ethnicity. But as Shannon mentioned, there are so many factors that contribute to the way we receive care, we receive healthcare. And some of those include age, sex and gender, income, your education, location, your access. And so all of those pieces, especially now, you know, we have to think about as well, like the digital divide, like your access to being able to, you know, use the internet or have access to a computer really can impact the way that you receive medical care and treatment, when the expectation in so many places now is, you know, make your appointments online. It's so much harder to get someone on the phone. Those are just small examples, but we as a program nationally are looking at all these factors across the, you know, 50 states across the United States, to really make sure that there's a representative sample of all the different people who fall into all these groups. Now for the Illinois Precision Medical Consortium, we are seeing that 87% and more of our participants do self-identify into one of these categories. Next slide. And this is just, again, supporting that, that idea that why is it important for this program and for any program that's looking to make a change in, you know, in what is health disparities that are across our nation. And we've seen so much of that through this COVID pandemic, and the negative impact that it has had on specific communities like the African American and Hispanic communities. We can see that right now they make up, you know, 13 and 17% respectively of the United States population, but their representation in clinical trials that then equal the kind of solutions, the treatment plans, the, you know, pharmacological, you know, solutions for health problems and diseases is so small. They're not represented. And so there's that aspect of, that aspect where that data point is missing, and we're looking to change that. And to kind of give you an idea of, you know, how we're doing at Northwestern and then walk you into the steps of enrollment, I just want to introduce one of my co-workers, Jenna, who will take it over from here. Next slide.
Thank you, Monica. So looking at how much has the program achieved so far, right? So we're talking about UBR populations, we're talking about goals. Nationally, we're exceeding our goals as a program. More than 80% participants identify as UBR, and greater than 52% identify as racial or ethnic minorities. Within the Precision Medicine Consortium, or IPMC, which is made up of Northwestern, Rush, North Shore, U of C, and UIC, we're also exceeding our goals. Approximately 87% of our current participants self-identify as belonging to one or more of those historic UBR populations. Next slide, please. As Monica and Shannon shared earlier, there is more to your health than just your medical record or what's on paper. You commonly hear, hey, it's not just your resume, but tell us why. Tell us about all these factors that go into it. Your biology, your genes, lifestyle, environment, they all help explain what makes you sick, healthy, and sometimes both. So again, a special thank you to Ben for sharing our speaker introductions, because that's, in my opinion, the start and one of the best ways we can connect with each other and potential participants if we're speaking about our program, sharing that why we've chosen to join all of us, whether that's as a participant, staff, or sometimes both. And I will highlight one of our important community partners currently is 50 Forward. 50 Forward has champion ambassadors who are currently sharing their personal stories or testimonials specifically within the local communities, which is currently rural Tennessee, but soon living in this digital virtual world, we're expanding into Illinois. So we're looking forward to connecting with more whys and not just communicate, but engaging those around us. Next slide, please. As we know, COVID-19 has disproportionately affected UBR populations. For instance, some of you may be familiar with some of the information on this slide. Hispanic account for 17% of the US population, but yet account for 33% of positive COVID-19 cases. So you can see that disproportionality right there. Moments like the COVID-19 pandemic are highlighting the importance of precision medicine. So looking at what will advancing precision medicine require to include people from all backgrounds. In this example, the Hispanic community, who have not always been included in research in the past. Next slide, please. The program is addressing COVID-19 in 3 ways. For those of you who are wondering, it's the hot topic of many of our minds, and rightfully so. We are conducting antibody testing, so supporting testing on samples from participants who have enrolled to help researchers better understand both the origin and the spread of COVID-19 in the US. We've also deployed COVID-19 surveys over the course of a few months to understand not just the physical impacts of the pandemic, but the emotional and psychological impacts as well. We are also looking at EHR data. So gathering that standardized information about COVID from participants' electronic health records to help researchers learn more about symptoms, as well as associated health problems. Next slide, please. Okay, so for those of you who are hopefully wondering, what does our participation entail? Once a participant creates an account in the participant portal, participants will be asked to complete consent forms and surveys and may be invited to share physical measurements and biosamples. That includes height, weight, hip and waist circumference, blood pressure, and urine, as well as blood or saliva. Participants then receive a $25 compensation after providing their biosamples, which again is in the form of blood or saliva because we're looking at that DNA component. And although the IPMC participant centers are currently paused due to COVID-19, participants are still able to complete that online portion made up of consents and surveys entirely from any location, so from the comfort of their own home. Next slide, please. One of the most recent surveys all of us has added, which we touched on earlier, is that COVID-19 participant experience or COPE survey. Just looking at understanding the health, including healthy aging and wellness means, including time as a factor, hence the longitudinal design, not just with COVID, but all different aspects of health. In addition to collecting the EHR data over time, all of us may follow up with participants through new surveys like COPE, opportunities to share wearable device data. Currently, we're supporting Fitbit and Apple Health, and or potentially even opportunities to provide new biospecimens. So if researchers are using blood, saliva, urine, etc., we might call you back and say, hey, if you're interested, you can come in and donate another sample. We're looking at your blood or your urine or your saliva, and we'd like you to continue providing samples to more researchers if that's something that interests you. Additionally, all of us will share opportunities to participate in ancillary studies. And actually at a meeting today that Monica and I were on, we learned that over 11,000 all of us participants volunteered to participate in a COVID-19 vaccine trial within 24 hours of an email going out to some participants, which is crucial while we're considering how COVID-19, as one example, has disproportionately affected those UVR populations. Next slide, please. Great. So I don't think we can ever say this enough, but all of us really truthfully views our participants as partners. So we want to offer the return of value to participants in various forms, including how participants compare to other participants who've answered the same questions, for instance, as shown here in the mobile app view of the participant portal. Our participants choose the amount of information that he, she, or they are interested in receiving. It can be as little as or as much as preferred. So what does that mean? We have emails, texts, we have newsletters such as My Medical Minutes that include 30-second fun reads from credible educational health sources that aren't necessarily always about research, but as featured in the news or social media. And as also alluded to earlier, participants are able to further choose the type of information they're interested in receiving directly in their participant portal. So newly, we've been returning genetic results, and that includes recreational as well as health-related information. So for example, very generally or briefly, ancestry and traits. Next slide, please. All right, so what is the promise for participants? Again, this is a long-term relationship, and the value to participants and researchers will grow over time. Together, it's an opportunity to fight disease, to learn about your own health, to access your own data, to ensure your community is included in research, to learn about additional research opportunities, if you so choose, and to meet individuals like you, or as we know it, network. Next slide, please. What can you do today? Become a champion. Provide our team with opportunities to communicate to potential participants or even current participants in settings such as today's, or through educational programming. In a time where we rely so heavily on digital connectivity, networks of National Library of Medicine, or NNLM, and all of us have partnered with the Public Library Association and Wisconsin Health Literacy to help people gain digital literacy skills and the support they need to stay connected, among many others. You can also connect with any site near you to request for information or materials. We'll be happy to share. And lastly, of course, you can join as a participant, which brings Monica and I to our last slide. And here you'll see some of the various platforms that we're on, and all attendees today will be sent some digital materials, including a brochure and a flyer, and a how to join link that's specific to this event. So Ben will be sending that out to today's attendees. Thank you.
Great, thank you. Thank you for that. If anyone has any questions, please feel free to put them in the chat. So one question I had for our participants is, Monica and Jenna, given the new administration coming in with 2021 right around the corner, do you anticipate any major changes to precision medicine? Are there any trends that you're seeing in the future that would impact some of the great work that all of us are doing?
I would say that the funding for this project, I think we can be really grateful that none of it was adversely affected through through any changes since it started 2 presidencies ago. So we're actually continued on track for in the last 4 years of the money that was set aside for the Precision Medicine Initiative, and all of us specifically. I foresee that it is going to continue to expand. And one example of that would be that, all of us expect that, that people ask me often, like, well, what is it that you guys are actually researching? And, there is not one thing that we're researching. The idea is to have a database and a resource, that's a resource to researchers with a variety of data points included so that they can get a really full picture, right, of individual health. Well, what that promises, I think, big picture, is that we're not, how would you say? I don't think that we have we didn't know 2 years ago that COVID-19 was going to be the hot research topic right now, right? So there's so many more things that might come down the pipeline. Right now, I know that in 3 years plan, they just made an announcement that there's going to be a nutrition arm of all of us that's going to be coming out, that's going to be looking at specifically enrolling participants with, their own protocol, but looking at like how they eat and then how that is impacted with all these other kind of data points. So I think this program is only set to grow larger. We're hoping within the next 12 months that the program is going to expand to children ages 0 to 17, because right now the program is limited to those who are 18 years old and up. So it is just going to continue to grow, I think.
Great. And then another question for Shannon. I know you walked us through kind of what you've seen in Chicago. Again, same question, given some of the administration, the new administration coming in, I know a lot of the local health departments are led, locally. Do you foresee any major changes to reducing health disparities? Do you think that, once we get past COVID, there'll be some changes? Just curious to get your expertise on that topic.
Sure, yeah. I'm not an expert in all things of the Biden care proposal, but there are two features of the proposal that, should it get passed through Congress, will reduce health disparities. They're both related to health insurance. The first is expanding coverage of health insurance through some sort of public option health insurance product that could be available to people that maybe cannot afford a private plan, but also don't qualify for either Medicare or Medicaid, that there could be some option available to that group of people. And then that would, the key result coming out of that implementation would be a lower uninsured population. So more people having access to these insurance vehicles that will make care more affordable to them. And then the second thing is, it's still related to health insurance, but less about coverage and more about the richness of health insurance, or what you can get out of your health insurance, where presently there is subsidy available to people who have an income up to 400% of the federal poverty line, but only on a silver level insurance plan, which is one of the more meager options on the insurance marketplaces. And the Biden care proposal is to make those same types of subsidies available on the gold plans as well, which means a little bit of a better insurance policy, meaning that the insurance company will cover more of the financial liability and decrease your out-of-pocket costs as a member of that insurance plan. So both of those two things together will, like we were saying, improve the coverage, which will make people feel more, healthcare will feel more accessible to them and available to them, because they're not as scared of being able to afford it. And then also, if you are already insured, but still feel like you have high out-of-pocket costs, it'll also be reducing those as well.
Great. Awesome. We have a question here from Lizzie. How is data protected? And I think this is a question for all of us in terms of data. Can you explain a little bit more how data is protected? Expand on that a little bit.
Sure, I can take that one. It's a great question, Lizzie. All of our data is encrypted and de-identified. So what does that mean in everyday terms? It means it's scrubbed of anything that could identify you as being a participant. So our data is accessed in 3 different tiers. Depending on the level of access a researcher or citizen science would apply to look at is really correlated with what their research is that they're doing. So not only do they need to agree to not try to figure out who our participants are, they need to abide by our code of conduct, our mission statement, and then also not identify who you are. Even in the face of law enforcement, we have an additional layer, I like to call it, of security and privacy, known as a certificate of confidentiality, which in the face of, we commonly hear about law enforcement asking for DNA evidence to link someone to a crime scene, so to speak. Unfortunately, we would not be releasing anyone's information for that. Our data, our biospecimens, our answers to surveys, our everything that we ask from the participant is completely protected, and it's only shared with you.
Great.
Does that help answer your question? Okay, great.
I like it. Any other questions from the audience? I know great session today. Really good information. Any other questions that folks have, regarding health disparities just overall or specifics around the All of Us program? Great. I think it's been some good conversation. We'll just wrap up here shortly. So a couple things. We will send out a link to this video at the end of this call. We'll send out also just how you can get looped in with some of the great work that the healthcare team at Slalom is working towards in addition to the All of Us program. We'll send out that material there. If you are interested in joining the leadership board or if you have any questions around Net Impact, please reach out to info@netimpactchicago.org and then also visit our website if you have any more questions. But I do want to, again, give a big round of applause to our speakers today. Some awesome information, and I do want to thank everyone for taking time out of your day, especially on a Monday, to come listen to this really important topic. So again, thank you all, and have a great rest of your day.